infectious. And so we have engaged in raising awareness among the general practitioners, dermatologists, and staff in health clinics, but also in the mainly affected communities through community organizations that know how to present messages so that they can actually be accepted. Now, while the majority of the cases so far are very mild, we have a few hospitalizations, but mostly people can actually stay at home. Already in May, published a risk assessment where we consider the likelihood of further spread amongst men who have sex with men as high. As well as to their close contacts, and the likelihood of the spread in the broader population as rather low. In the joint document that was also mentioned that we released yesterday together with the colleagues from WHO, we address public health authorities directly to prepare for the summer and the events associated with this time of the year, because on the one hand, large gatherings represent an easy environment for the transmission of monkeypox virus if close, prolonged, and frequent interactions among people, in particular sexual activity, occurs. On the other hand, they also present a excellent opportunity for outreach activities and public health interventions. So we have advised against venue closures and event cancellations, because that might just, I mean, the activities may still occur, but less be for awareness raising and other interventions. So we have recommended both to the public health authorities, but also published a guidance for gay and bisexual men and men who have sex with men to how to approach this summer festival season. And this direct engagement with the communities and with the community leaders is very important now to see how we can raise the awareness and try to prevent, or at least raise the awareness that people come forward when they have symptoms. Because I fully agree with Hans Kluge that stigma is something that is really counterproductive, and in my view, just also inappropriate. The disease doesn't select, the virus doesn't select according to sexual orientation. It just uses opportunities for transmission. And so it is very important that everybody is aware of the symptoms and what they can do once these symptoms occur. So we say that after the diagnosis is made, contact tracing even of a portion of cases and isolation of those cases and contacts identified can be effective to control the monkeypox in Europe. So we urge everybody with symptoms to consult their healthcare providers as soon as possible to decrease further spread, and to keep contact details as much as possible of those close contacts or sexual partners, as this may help in contacting those and also see whether their infection has occurred. So stigma should not prevent access to healthcare, and here we should really take care of each other, public health practitioners and communities at risk. Thank you.
Thank you very much, Dr. Amon, for that. As has been mentioned already, this specific outbreak is concentrated in men who have sex with men, and that's why WHO Europe has been engaging with the community from the outset to ensure that they can help co-lead the response. So for more on this, I'd like to give the floor now to Mr. Steve Taylor, Director of European Pride Organisers Association. Steve, please, you have the floor.
Thank you. On behalf of Pride organisations across Europe, we'd like to thank the World Health Organization for their efforts and expertise to ensure that the response to monkeypox is rooted in evidence and fact, and for their commitment to work with civil society organisations like the European Pride Organisers Association. This summer, Europe will be host to around 750 Pride events at which the LGBTI+ community comes together to celebrate human rights, love and equality, but also to campaign for equality and human rights in places where they are yet to be realised. This is the 50th year in which Pride has been celebrated in Europe, and its relevance and its importance has not been diminished. We are reassured by the clear statement from WHO that major events, including Pride, should not be cancelled or curtailed because of the outbreak of monkeypox. And as Dr. Kluge said, we are in fact a powerful opportunity to raise awareness. We have been working with WHO over recent weeks to develop our messaging, and we will encourage Pride organisations and event producers across Europe to use their events to raise awareness of the facts about monkeypox so that people can protect themselves, their loved ones, and their communities. Sadly, but entirely predictably, some of those who oppose Pride and who oppose equality and human rights have already been attempting to use monkeypox as a justification for calls for Pride to be banned. There is no depth to which our opponents will not descend to try and stop Pride, and we are pleased that the WHO guidance is clear that Pride and major events should not be affected and are, in fact, opportunities to share important public health messaging. As responsible event organisers, our member Prides will use this opportunity to raise awareness. For the last 40 years, Pride organisations have been at the forefront of public health information and visibility around the HIV/AIDS epidemic. Our community understands risk, but we also understand safety. And so we say to LGBTI+ people across Europe and to our allies that you should welcome the return of Pride to our towns and cities this summer, including Europride in Belgrade in September, and we invite you to join us to make a difference and to keep our community safe.
Thank you very much, Steve, for those words. So we're going to open up to the Q&A part of this press briefing now. And as I said before, please raise your hand to ask a question and do introduce yourself and your outlet. We've also received some questions in advance, which I will go to in a moment. So without further ado, I'd like to go to Helen Collis. Please, Helen, if you could unmute yourself and also just let us know your outlet.
Thank you very much. Yes, my name's Helen Collis. I'm a journalist for Politico Europe. Thanks so much for holding this event this morning. I'd first like to understand if there has been any modelling done within the World Health Organization for us to understand what the case numbers might get to in Europe this summer if containment of these outbreaks is not reached. And then a second question, if I might. Given the reports from public health agencies that some of the cases in these outbreaks appear to be less severe than would be typically expected, and given that the older vaccines such as ACAM 2000 come with, although they're not authorised for monkeypox, but are for smallpox, they come with quite a lot of side effects. Are there any situations currently where you think that the benefits of using these older vaccines outweigh the risks in the current outbreaks? Thank you.
Thanks very much, Helen, and I'll give the floor straight away to Dr. Smallwood.
Yeah, thank you very much, Helen. And perhaps this is also a question that Andrea Amon might like to answer in terms of the modelling that's gone on in European Union countries. But for the moment in WHO, we're working with countries to get a better grasp on the case-based information, detailed case-based information, and that we're doing jointly with our ECDC colleagues. We've already collected a subset of information around particular cases, and we're looking at that detailed information and analysis to better understand what the information we already have, and any modeling will then be based on some of that more factual data from what we've seen in the past month. In terms of the severity of the disease, as you said, many of the cases are presenting with clinically what we would call mild initial symptoms, but we have seen some cases progress into quite nasty complications, and we have seen a small number of hospitalizations because of those complications, which include things like secondary infections. So, of course, although the initial cases are potentially mild, the progression of the disease is over several weeks, and we need to learn a little more about that before being categorical in our assessment. When it comes to vaccinations and vaccines, as you rightly said, there are several different products that are being considered for potential recommendation and use in the context of monkeypox. The clinical data around these is still scarce, and so the use will be in a research environment. And of course, for those different products, they will have different safety profiles, and any use of those vaccines in post-exposure prophylaxis, for example, would have to be based on a very specific benefit and risk assessment in discussion with the patient or the person who has been exposed. Over from my side.
Thank you very much, Katie. Dr. Amon, would you like to add anything? I think we're okay there. Okay, so we'll take a question we received.
Sorry.
Hands. It's a question coming from actually from Lucy Middleton from Thomson Reuters, who I also see is online. Lucy, would you like to? I can ask the question on your behalf. Thomson Reuters are asking why are monkeypox cases predominantly occurring in the MSM community, that is, men who have sex with men? Can I give that question to Dr. Smallwood?
Yeah, thank you, Banu. Well, all outbreaks start somewhere, and as both the regional director and Dr. Amon said in their opening remarks, this virus doesn't choose any one person against another. It's opportunistic in its spread, and how it will spread will really be defined by the opportunities it has. It's also a disease that has an incubation period of 21 days. We're just over a month into this outbreak and understanding this outbreak. So it's too early to conclude as to how this disease will be spreading amongst the general population. We do also have some cases amongst whom are not the MSM community. So we do have family clusters. We do have indications that there are small numbers of cases among individuals outside of this particular group. So the virus will continue to spread in the population. We will take measures to block that opportunity for the virus to spread and control it as we do in any particular community. So really it starts somewhere. It will spread to other areas geographically and in different community groups. We do expect that further spread to occur, but we can control that by taking swift and rapid interventions.
Thank you very much, Dr. Smallwood. Just before going to our next question, I see Dr. Andrea has a hand up. Dr. Amon?
Yeah, can you hear me? Because I was speaking before and apparently you couldn't. So just to the question from Helen Collis, we have started our modeling, but as Katie Smallwood said, the data are scarce, so the models are work in progress. We also model not only the unchecked spread, but really the spread with different scenarios of interventions, and so that is what is in progress. So we can't come up with definite figures yet, but we hope so that in the course of next week we have a bit we are a bit further on this. Regarding the vaccination, it is so that the vaccine is not licensed in the EU or authorized in the EU for monkeypox, but in the US it is. But the idea that is that it's still due to the scarcity of safety data, an individual risk-benefit consideration between the person and the healthcare provider.
Thanks very much for that. Dr. Amon. Let's take a question from the live question now from Natalie Grover at Reuters. Natalie.
Hi, good morning. Thanks very much for taking my questions. I wanted to start with some interesting data that came out of Italy in recent days. They found some evidence of monkeypox virus DNA in semen, including one patient with evidence of virus that was shown to be able to replicate in the lab. I'm just wondering if this emerging data has you concerned about potential changes to the transmission ability of the virus, and then secondly, if you will, you know, it's been a while since WHO and sort of scientists across Europe and beyond have been looking into what's the origin behind this outbreak, and you know, just trying to get a sense of what's making it spread in the way that it has. I was just wondering if you could talk a little bit about how the understanding of this virus or this outbreak has changed over the last 6 weeks or so. Thanks very much.
Thank you very much, Natalie. I think I'm going to have to go back to Dr. Smallwood on this one. Dr. Smallwood, you have the floor.
Yeah, sure. Just in terms of some of the findings in semen, as was published last week, there are some patients among whom have had semen tested for virus and come back positive. So that's something that we're looking at. It doesn't change our assessment of the current transmission routes that we're seeing at the moment, which are very much largely based on very close physical proximity between individuals, skin-to-skin contact, skin-to-mouth, and that's really what's driving the transmission at the moment. And however, in terms of our recommendations for patients who have monkeypox, once all of the signs and symptoms of monkeypox, including the complete resolution of the rash and the scabs, has resolved, we still recommend patients to practice safer sex with the use of condoms for up to 12 weeks as a precautionary measure, whilst we further understand the presence of virus in semen and other bodily fluids. In terms of the reasons behind this outbreak and what we're learning and what we've continued to learn, of course, monkeypox, as well as being a widely neglected disease in the endemic regions where it's known to circulate, has seen a significant resurgence. And I think we understand that to be partly because of the waning immunity from smallpox vaccination, and is clearly developing a niche in terms of transmitting from humans to humans. Certainly, we're still trying to understand how this particular outbreak is different, how the pattern of transmission is different. We need to do more to better understand what the transmission patterns are in endemic countries as well as non-endemic countries. And we're also looking at the clinical presentations to understand how they might be different. At the moment, there's no significant evidence to point to a change in the virus. So we're continuing to look at these questions, and these remain some of the big unanswered questions that WHO and other partners are looking at through the research and development blueprint, and to really try and galvanize member states, public health institutions and communities to contribute that knowledge and to accelerate the learnings that we're doing.
Thank you very much, Dr. Smallwood. Dr. Amon, would you like to come in, or I can move on?
No, I have nothing to add. I think Katie said it all.
Great, thank you. There's the next question here we've received from Maria Cheng from Associated Press. I'm going to go to the regional director and then to Dr. Smallwood. And the question is around vaccines and access. So does WHO Europe expect smallpox vaccines to be sent to high-income countries like the UK, France, Germany, Italy, since they have the biggest outbreaks? And if so, how unusual is it that vaccines would be dispensed to countries that could otherwise afford them? Dr. Kluge, would you like to come in at all?
Well, first, there are several steps that we need to go through to address the demand issue, whether it's for lower, middle, or upper income countries. And as was mentioned already, currently there's only one vaccine that has been approved for monkeypox, and the production capacity indeed has not been scaled up yet. And as Dr. Ament was mentioning, the particular regulatory work has not been done yet. But we are trying to prepare now for the distribution of vaccines, working very closely with the member states and partners alike to design an equitable mechanism for a fair distribution of the vaccines. And before going to Dr. Smallwood, I think everyone is aware of the COVAX mechanism, which actually was designed for all countries, independent of their income status. So in that sense, there is a bit of a precedent. Over to you, Katie.
Thanks. And just to add that in addition to COVAX, there's allocation mechanisms that WHO is very much involved in for other epidemic-prone diseases such as meningitis, yellow fever, cholera. And I know my colleagues in our headquarters office are very much involved at looking at engaging directly with some member states already that have some vaccine stockpiles, but also engaging with other partners to establish an allocation mechanism that will be fair, equitable. It'll certainly be based on needs, epidemiologic situations, response strategies, and of course, based on the readiness of the country from a regulatory perspective to receive any vaccine products. So I would just end my comments there.
Thank you very much. I'd like to bring in Steve, if I may, on advocacy with regards to events organizers and some of the events that are taking place, including Pride this summer. How do you go about engaging those most at risk? Maybe some practical tips on how event organizers should be engaging with the MSM community and beyond.
I think there are several ways, and really the best way to think about it is about the journey that someone goes on through their interaction with your event. So that will begin perhaps with social media or with media interviews that your team might give on radio or television talking about the event coming up. There are opportunities to say that if you have symptoms of monkeypox, then you shouldn't come to the event. If you develop symptoms when you're at the event, this is the behavior you should adopt. And then also aftercare, so that after the event, you're sharing information that if people develop the symptoms, they know how to engage and where to go to get help. But there's also important messaging to share on big screens at Pride events, in posters, in event guides, in apps, to say, this is not, as my colleagues here have said, a condition that is restricted only to men who have sex with men, although that's where the current cases have been. It is an opportunity to challenge that stigma and to say that anybody can be affected by monkeypox, and these are the symptoms to look out for. So just to think about every opportunity that there is during your event to get the message home that this is what to look out for and this is what to do if you find the symptoms, but to use every opportunity to challenge the stigma because that's really just going to push people away from seeking help when they need to do so.
Thank you very much, Steve. I see Helen has her hand up. Helen, is that an old hand or would you like to ask?
It's more questions.
Go for it.
Thank you. You mentioned earlier that there is sort of research happening into whether or not this is as a result of sort of smallpox vaccinations not covering the population because they were ended such a long time ago. Is there an argument here for the return of smallpox childhood vaccinations, firstly? And then secondly, are you able to update us on what WHO has in its stockpiles of smallpox vaccines? Thank you.
Thank you very much, Helen. I think I'll go to Dr. Smallwood.
I think on the question of the smallpox vaccine stockpiles that WHO maintains, I think that would be best directed at our colleagues in headquarters. Just very specifically on the question on the potential return of smallpox vaccination among younger children, I think that's a very interesting question to ask at this stage, but I would point towards the difference between smallpox and monkeypox, and that's namely that monkeypox has a continuous animal reservoir, which smallpox does not have. So smallpox is the only human disease to have been eradicated, which is something that was achieved through huge worldwide collaboration during the Cold War period, and that's something that has really rid humanity from a pathogen that we won't expect to re-emerge. Monkeypox has taken advantage of potentially this new niche and this new ability to spread with waning immunity in the human population, but it really counts on this zoonotic animal reservoir.
Thank you very much, Dr. Smallwood. And perhaps, Hans, Dr. Kluge, you might want to reflect on the solidarity needed to address monkeypox.
Thank you, Banu. That's an incredibly important point, which I mentioned during the statement. As I also had the video conference this morning with Dr. Moweti, the region director of the African region, that we have to join really together, not to see this kind of more selfish rush from higher income countries to use the few medical countermeasures present, but look from a global equity perspective. Actually, there's still 33% of the population globally which haven't received one shot of the COVID-19 vaccination. So this equity globally is still not solved till the end, and we have an opportunity now to do better.
Thank you very much. So I'll take a question from the floor. Ulrike Till, if you could unmute and also let us know which outlet.
Yes, hi. I'm with SWR, that's an outlet of German public radio. And I have a few questions regarding transmission. So the first is, you mentioned close face-to-face contact and droplets, but as we remember from COVID, the line between droplets and aerosol transmission is a thin one. So at this point, are you concerned that, contrary to what we think to know about monkeypox, this could also be transmitted via aerosols? And secondly, since the virus seems to be very stable on surfaces, much more so than SARS-CoV-2, what about doorknobs in public buildings? What about a hotel bed where someone infected with monkeypox who didn't know it, him or herself, has slept before? So to me, that seems that there seem a lot of ways where people, who don't take part in festivals just catch it by chance. So what do you say to these possible ways of transmission?
Much, Ulrike. I think we'll go to Dr. Smallwood, and then perhaps Dr. Amon would also like to come in on one or both of those. So, Dr. Smallwood.
Thank you, Ulrike. And this is a very good question. And I think we can be clear that COVID-19, SARS-CoV-2 virus and the monkeypox virus are very different. And we really need to consider the differences in the ways that they transmit between individuals. I think we can be clear that the monkeypox virus does not transmit through the respiratory route with the same readiness as SARS-CoV-2. Does that mean that it can't happen at all? No. There are some circumstances and situations where that can happen. We do have patients that have sores and rashes in the mouth or the back of the throat and who test positive on throat swabs. So WHO's infection prevention and control guidance does make very specific reference to this and makes specific reference to some respiratory precautions that can be taken in that type of situation around patients who have confirmed monkeypox. As you say very well, it's also well known that monkeypox can also transmit through contaminated belongings of patients. And WHO's guidelines and ECDC's guidelines also do put out some very specific recommendations about how to prevent that from happening, especially when patients are isolated at home and being cared for potentially by other household members. But in terms of the current spread, as we've said before, this is very much dependent on very close and potentially prolonged physical contact, where there is specific close contact, including during sexual activities, which is really very much leading to the transmission between humans at the moment. Perhaps I can hand over to others on this.
Dr. Amon, would you like to come in?
Yeah, I think it's very important to keep in mind that while there are several ways of transmitting, we have to keep the closest attention to those that are most frequent and to concentrate the control efforts with a priority on those that are most frequent, which are the ones through close contact, close direct contact. And that doesn't mean that we should neglect the others. And as Katie has pointed out, we have considered the other ways of transmission in our guidance documents, but we shouldn't turn it around now, saying that things that may happen occasionally are the main mode of transmission. I think we have to be very clear. We have to tackle and also raise the awareness about what is the main way how this virus transmits. Thank you.
Thank you very much, Dr. Amon. We've received another question here in the chat from the London School of Hygiene and Tropical Medicine, and he's asking about whether any sequencing has been done or isolated in the European infections that we have found, and if so, how does that case fatality in Europe compare with that of the African clades of this virus? Would either Dr. Smallwood or Dr. Amon like to take that one?
Well, I can start if Katie is okay.
Sure. Please go ahead.
Okay, so so far those samples that have been sequenced all point to the West African clade. That is of the two types of monkeypox virus that we know of, the more benign one, and in African countries associated with a case fatality of 3.3%. So we encourage the sequencing also because to monitor whether there are changes in the virus, but so far we have not seen a shift in the genome of those where we have sequences from. Over to you, Katie, if you want.
Thank you very much, Andrea. And only to add that thankfully in the European region, we've had no deaths registered in the current outbreak at the moment. But we should be prepared for those to happen, because we do know that monkeypox can be a severe disease. And we have some patients who are hospitalized. And we do know that it can lead to particular severe outcomes in several population groups. And that's young children, that's pregnant women, and that is also individuals who are immunosuppressed. And as the virus continues to spread and affect different population groups, we will likely see some severe cases. But at the moment, as I said, there have been no deaths yet reported in the European region.
Thank you very much, Dr. Smallwood. I'll take a question we received in advance from AFP, from Camille Basvolet. I'll go to Dr. Kluge and then for anyone else who would like the floor. The question is, are you concerned about mutations and variants, the way COVID mutated? And importantly, is it too late to prevent a pandemic of monkeypox? Katie?
Yeah. Sorry, could you repeat the question, please, Banu?
Sorry. Are you concerned about mutations and variants, the way COVID mutated, and is it too late to prevent a pandemic?
Right, thank you, Banu. So the monkeypox virus is a double-stranded DNA virus, which gives it more stability and less scope for rapid mutations. So we are not expecting the same rate of change in the virus that we'll see in other types of viruses, such as, for example, SARS-CoV-2. Having said that, we're still looking at the way the virus has entered the populations outside of endemic countries and the antigenic difference between the cases that are circulating in Europe and other non-endemic countries versus those that are circulating in endemic areas. But at the moment, as we've said, there's no significant change. In terms of pandemic, we need to focus very much on preventing such a situation, and that, I think, has been outlined quite clearly both in the statements from the regional director but also from our colleagues in ECDC.
Thank you, Dr. Smallwood. Dr. Amon, would you like to come in, or we can?
No, I just can emphasize that all the efforts that we are now undertaking are really to prevent that it's a further spread. We may still see some further spread, but we really, the effort is directed towards preventing exactly a pandemic.
Thank you. Let's take a question from the floor. Lucy Middleton, I believe, from Thomson Reuters. Lucy?
Hiya. I just wanted to ask, you talked earlier about the different ways of transmission with prolonged contact, and there's been evidence of monkeypox DNA being found in semen in a handful of cases. Does this mean there is a possibility of that monkeypox could be sexually transmitted? And does this mean that monkeypox is changing if that is the case?
Thank you. I believe this was sort of answered in an earlier question, but perhaps Dr. Smallwood or Dr. Amon could just briefly touch on it.
I can jump in. Yes, so I did allude to this, well, I did answer that question earlier. So some semen samples have tested positive for monkeypox virus amongst some patients being treated in Italy, and those have been published in Eurosurveillance. Again, I would reiterate exactly what Dr. Amon stated previously, that we really need to focus on the most frequent mode of transmission, and we clearly see that to be associated with skin-to-skin contact. Nevertheless, in our recommendations, we do already have precautions in place for patients who have fully recovered. So let me just re-emphasize that for patients who have monkeypox, for the time that they're ill and until the moment where their rash has fully resolved, we really recommend that they do not undertake sexual activity during that time. after that period, we also recommend that as a precautionary measure, they use condoms when they have sex, and that would prevent any ongoing transmission that could occur. And we still don't know if that does occur during from semen. In terms of whether this represents or would represent, because again, we do not know, that it can be sexually transmitted through sexual fluids. We don't know whether that would be a change, and this may have been something that we were unaware of this in this disease before. And this just highlights how neglected this disease has been and how much we're learning about this disease as it spreads at the moment. So this again just underlines the fact that we need to invest more in these diseases that we've long neglected in endemic areas, because they will be potentially a threat to other parts of the world.
Thank you very much, Dr. Smallwood. Well, I think we'll take, Helen, I think you have your hand up again. So just very quickly, your final question.
Thanks so much. I have so many questions. Some people have suggested that maybe the vaccination campaigns should be expanded to be offered to all men who have sex with men. Is this something that the WHO is considering in its guidance? And if not yet, at what point would that be something to be considered? Thanks.
Thank you. Again, Dr. Smallwood or Dr. Amon, whoever would like to come in on that one.
I can just reiterate what our current recommendations for vaccination say, and those were issued by WHO yesterday. And in those recommendations, we recommend that all contacts of cases who have moderate to high risk of exposure may be considered for post-exposure prophylaxis. That should be regardless of the group of individuals, or whether they're men who have sex with men, or healthcare workers, or other individuals' household contacts.
Thank you. So I don't see any further questions online. Before closing today, I would like to maybe just give the floor to Steve first for any final thoughts on the advocacy that's needed for monkeypox, and then some final words from the regional director. So Steve, please, you have the floor.
Thank you, and thank you again to WHO for really raising awareness on the importance of ensuring that we deal with facts and evidence around monkeypox. Prides will return to streets this summer. They are an important opportunity for communities to come together, and across Europe we need governments, we need health authorities, and we need civil society to ensure that we enable and value prides going ahead, but also use them to share public health messaging and make sure that as many people as possible know about monkeypox and how to be safe and how to stay safe.
Thank you very much, Steve. And any final words from you, Regional Director?
Thank you, everyone, for participating, particularly the co-panelists, Andrea, Steve, Katie. And I think to reiterate our call for global solidarity, because we see again that an issue which is not being tackled in one part of the world quickly becomes all our concern. Number one, and number two, that we also learn the lesson from the COVID-19 to communicate in times of uncertainty. So what we're sharing today is what we know today, but is evolving. So do not hesitate to reach out to the WHO Regional Office for Europe for any further questions. Thank you so much, and stay healthy.
Thank you very much. And on that note, let me close our press briefing for today. Thank you, Regional Director. Many thanks to our panelists, Dr. Amon in Stockholm, Steve here in the studio, and Dr. Smallwood as well. And thank you to you, members of the press, for joining this media briefing. If you need additional follow-ups, I know there were some questions we might not have been able to get to. Please do email us, and we will do our best to answer those questions. So, as always, stay healthy, take care, goodbye.